I will be giving the last talk of this session. It's the last talk before lunch, so I'll try to be brief. But I want to talk to you guys about techniques to remove difficult, really bile duct stones. All right, and bile duct stones are the most common indication for doing ERCP, but it's not always straightforward. And so let's talk about how to remove the difficult ones. So my disclosures: I'm a consultant for Boston Scientific, and here's an outline of the talk. We'll talk about ERCP and common bile duct stones. We'll define what a difficult CBD stone is. A stepwise approach to removing these stones, including techniques and different devices that can be used, and an algorithm to guide management. All right, so common bile duct stones. So 10 to 20% of patients with symptomatic gallstones, so stones in the gallbladder, will also have stones in the common bile duct, and ERCP is the standard of care for removing these stones. And the goal, in general, is to remove the stones or the large stone at the time of the index procedure. So most patients who come with a stone, you do the ERCP, you remove the stone, and that should be it. That should take care of the whole issue. And you can confirm this by having a cholangiogram that has no stones at the end of your procedure, or doing balloon sweeps where you have no more stones or debris or sludge, no resistance in the bile duct. But in terms of ERCPs, you always want to be prepared, right? So by failing to prepare, you are preparing to fail. I'm not a big camper, but part of the reason is because I don't do a good job preparing. But if you are going to go camping, you got to make sure of a lot of things. You got to know how to make your tent, make sure your mattress fits inside the tent, your toilet paper doesn't get wet, there's no electricity, so be prepared. And so for ERCP, you got to make sure you review the anatomy in advance. Most patients who have an ERCP have imaging before they have the procedure, right? You don't just go straight to an ERCP. There's usually something that indicates they need an ERCP done for a stone. And if there are stones, you want to know how many are there, how big are they, and where are they located. So in terms of removing stones, in general, you need to create an exit path to remove the stone from the bile duct, and then you're going to proceed with removing the stone. And in general, let's just talk briefly about simple stones. A sphincterotomy is usually sufficient for creating an exit path. So you get into the bile duct with a guide wire, you put the tome up, and you do a small incision. That's your sphincterotomy. And they can use balloons to remove the stones by pulling the balloon down the bile duct, or using other devices. This is the very simple, basic, straightforward ERCP, just so we're all on the same page here. I'm always surprised sometimes when I hear about, people do ERCPs or involved in ERCPs, but have actually not actually paid attention to what goes on during the case, right? But this is a cannulation, the sphincter tome, get in, shoot contrast, confirm you're in the bile duct. This is fast forwarded because no contrast injection goes that fast. And you're going to fill the duct. See, there's a filling defect there in the bile duct. That's your stone. Do a small sphincterotomy. This is the cut that's made. Then take the balloon, sweep the bile duct. And this is maybe one of the more satisfying parts of our job. When you see the stone come out, it's like birthing a baby. And starts the crown, and there's the stone. Somewhere around here. There. All right. So you can use a balloon. You can also use baskets to remove these stones. And 85% of the time, we're able to remove the stone on the initial index ERCP. But 15% of the time, they're difficult. So what defines a difficult CBD stone? All right, and this is Indiana Jones running away from this big stone. All right, so some define as difficult stones having more than 3, some say more than 10. Size greater than 12 to 15 millimeters, that's a big stone right there in the bile duct. You see that big filling defect. Can be difficult if the stone doesn't match the size of the duct. So you see the duct is very small in the bottom left-hand corner, the stone's very big. So getting that big stone through that small duct is going to be difficult. If the stones are in the intrahepatic bile ducts or in the cystic duct, it can be technically more challenging. And certainly anatomy, right? So if you have had surgery on your GI tract, it make it more difficult. If there's stricture in your duodenum, it makes it hard to pass your scope to the duodenum where the ampulla is located. Or if you have a bile duct stricture or a sigmoid-shaped bile duct, right? And this is just examples of a couple different surgeries people have had, which can make the ERCP more challenging. As we talked about, for simple stones, basically 2 steps, right? You create an exit path, and then you remove the stone. For difficult stones, you have to do the same 2 steps, but you're going to add a few more, right? So 1, you might need to make the stone smaller in order to get it out. And lastly, you have to consider the possibility that you can't get the stone out or can't get all of it out in 1 step or 1 procedure. So let's talk about the 4 steps for removing difficult stones and what you can do about each one. So in terms of creating an exit path, we talked about sphincterotomy. But another way to create an exit path would be this technique called a dilation-assisted stone extraction. So the idea is you take the stone, there's the tapered distal CBD, you perform your sphincterotomy like before. There it is, your small incision. And now you put a balloon, a dilation balloon, up across the sphincter, dilate the balloon, and then you can remove the stones with balloon sweeps with a much bigger opening, okay? So just to give you an example of this, there's a cholangiogram with some big stones in the bile duct. You see the balloon there in the upper right picture, a balloon's going up. You see the contrast in the balloon, there's a small waist where it's stretching open the ampulla. The picture there endoscopically in the bottom left shows the dilation balloon, and then you can see the stones being removed. It's a great technique for removing large stones with a small distal CBD. It can be performed after a fresh sphincterotomy or prior sphincterotomy. And this technique is equally as effective as lithotripsy after sphincterotomy with fewer complications. So here's this technique in video. This is the dilation balloon going up, making the opening to the ampulla or the distal CBD much larger. And you can see how this would facilitate removing larger stones. So after this is done, you can see how much larger the opening is to the bile duct. See how big that opening is there. Subsequently, removing stones is much easier. I'm just going to show removing stones here. All right, and there it is. Okay. So that's another technique to making the exit path larger. Now, in terms of making stones smaller, there are a couple of techniques. One is mechanical lithotripsy. This is the idea of using this large basket to break up large stones, to crush them into smaller pieces. So here's an example of this technique. There's a large, giant stone in there. Put this huge basket around the stone, and it's going to crush the stone into tiny fragments. You're going to see it pop right when it breaks up the stone. Right? They're cranking this lithotripter at this point, and it popped right there, and you can see it in much smaller pieces. It's all fragmented there. And this will make it easier to remove this large stone through the bile duct. There are all the pieces. All right. So there's a pretty high success rate. 20 to 30% of the time, though, they require more than 1 session because there are lots of pieces in there. And the biggest issue with this is that when it fails, you can have the stone and or the basket stuck in the bile duct. Okay? If it's stuck there, you may have to take the patient to surgery to remove the stone and the basket. And so while this is quite rare, I don't like using baskets for this reason. So I've never had to go to surgery, but the 1 or 2 times you had a basket stuck in the bile duct and you're yanking really, really hard to try to get the stone out, or it doesn't break the stone the way you'd expect it to, it's a little stressful in the procedure to have the basket stuck in the bile duct and you can't get it out. All right, so for that reason, I don't like this technique, but certainly some people are very comfortable with this, but is the kind of traditional way of breaking up stones into smaller pieces. To me, I think the better or easier technique is to use cholangioscopy-assisted lithotripsy. And to me, this is a game changer in the field of ERCP. So this is cholangioscopy. You may be familiar with this, right? This is a little tiny camera that goes inside the bile duct to allow you to visualize inside, as opposed to just using a cholangiogram to determine what's in the bile duct. And with cholangioscopy-assisted lithotripsy, there are 2 different methods. One's EHL, or electrohydraulic lithotripsy. The other is a holmium laser. We'll talk about EHL first. This is a probe that with 2 electrodes that creates a high voltage spark, and that creates an electric current, and it breaks up the stone by using this spark of spherical shock wave. Okay, so to me, this is like Street Fighter 2. Some of you guys played this game. This is Ryu versus Ken. They both are able to throw this fireball, and to me, this is like EHL, right? This creates this little shock wave, and that's what breaks up the stone. So in this technique, you fill the bile duct with saline. Right? Your cholangiscope's already in the bile duct. You place the probe or in front or in center of the stone, as you're to see in this video, and then you just blast it, right? It's almost like a video game, kind of like Street Fighter 2. You try to avoid contact with the bile duct wall. Depending on the EHL machine you use, I like to start with a power of medium, pulse is 15, I go up if it's not breaking up the stone. The success rates are very high. The main risk is perforation, but that's if you're really kind of being careless and EHLing the wall of the bile duct. So that's also very satisfying. So the other technique is holmium laser. This is basically a laser using photothermal energy to create a drilling process to break up the stones. The absorption of the laser light by the stones leads to fragmentation. So this is like Austin Powers preparing the laser. So question for the audience here. Which is the better cholangioscopy-assisted lithotripsy device? Oh, you can do it now. So shoot your phone at the QR code, and you can pick A, EHL, or B, holmium laser. Which is better? We got 1 vote for 100% EHL. You guys, 5 more seconds. All right, so we got about 70-30 EHL versus holmium laser. Pretty good. Can I go back to my slides, please? All right, so this is Ryu versus Austin Powers. And the results, no significant difference.
I know.
Okay, they both work, okay? The idea is you put a camera inside, you break up the stone in small pieces, whatever technique you use, it'll get the job done. So no difference in adverse effects. Only one difference was found in this one study, which showed that the EHL group took a little bit longer time. All right, but the point is, you get the stones out. All right, in terms of, let's move on to the next step. So removing the stone, we talked about balloon sweeps and baskets. Another way to remove the stone is working the axis of the bile duct. This just means when you're pulling the basket of the balloon through the duct, you got to remember where your forces are, and this is more to do with the physicians who are performing the ERCP. When I hear axis of the bile duct, I keep thinking of Dr. Muthuswamy, who mentored me and taught me how to do ERCP. That's all he would say all the time, axis of the bile duct, work in the axis of the bile duct, because the forces, if you just pull, are going to go lateral. You actually want to pull down the bile duct if possible. So you align the scope with the axis of the bile duct. There are a couple of techniques you can use to help get you in that axis and then help you remove stones so that you don't impact the stones into the distal CBD. And then the last thing I'll talk about is incomplete stone clearance, okay? So while these techniques work most of the time, there are going to be instances where you can't get all the stones out of the bile duct. So what can you do about it? So one is saline irrigation. The idea basically is you maybe you've broken up the large stone, there's lots of little pieces in the bile duct, you've done lots of sweeps, you keep getting little pieces out, your cholangiogram shows that you still have pieces of stones in there, and these stones that are left behind can result in cholangitis, recurrent stones, recurrent symptoms. And so this was an RCT that was done in 5 hospitals in Korea that looked at saline irrigation of the bile duct after complete, or thought to be complete, ductal clearance. And so it was pretty simple. You just take the balloon tip catheter, you infuse 100 milliliters of saline into the bile duct, and then you sweep again and again afterwards until the bile duct was cleared. And then if they define residual stones as stones confirmed on imaging and or ERCP within 6 months after this procedure, or patients presented with cholangitis and confirmed of a stone on ERCP within the 6 months. And what they showed was that residual stones were found in 6.8% of this group that got saline irrigation versus 23% in the standard group, which is very high. No difference in complications. The saline irrigation added 3 minutes to the procedure, right? So a pretty simple technique, but the idea is to try to flush out all the stones out of the bile duct. Another technique is cholangioscopy. This is just simply putting the camera back in the bile duct after you think your bile ducts are clear. You insert the cholangiogram to the hilum, and residual stones were found up to 22% of patients. Now, the last thing you can consider doing is stent placement, right? So maybe you've done a procedure for 2 hours and you've taken out this large stone and you still feel like you haven't cleaned out the stone. What else can you do at the end of the procedure? So another option is to place a stent. So if you're unable to achieve complete duct clearance, you can leave a stent to ensure biliary drainage. Stents may make it easier in the future to decrease the size of the stone. So you put a stent in, you come back, the stones are smaller and easier to remove. It helps fragment the stones in up to 72% of patients. And it may help relocate stones that are in the intrahepatic bile ducts. They may come down into the bile duct to make it easier for you to remove the stone on your subsequent procedure. What about only stent placement? So there are situations where maybe the patient has cholangitis, you just want to get in and out quickly, just put a stent and run. Don't actually take the stone out in that next procedure. You could do sphincterotomy and stent placement without stone extraction. After 4 months, they found that the stones decreased in size from 16.6 to 10 millimeters, and then the rate of duct clearance at the second ERCP was very successful. All right, so maybe this is a weekend case, a late night case, patient's very sick, just get in and out, worry about the stone at a second procedure. There's also the consideration of placing a metal biliary stent. So again, if you can't achieve complete duct clearance, you may want to leave a stent to ensure biliary drainage. You can place a metal biliary stent instead of a plastic stent. These metal biliary stents are much wider in diameter and may give you more stent patency. So when to consider using it to facilitate passage of stone fragments after lithotripsy, right? You leave a big metal stent in there, help pass all those small stones through the metal stent, or to dilate the sphincter to allow removal of larger stones on your next procedure. There's a small risk of cholecystitis because your metal stent can block off the cystic duct. There's been no comparative studies comparing metal stents to plastic stents. And there's always the question of cost effectiveness, as these stents are a lot more expensive than plastic stents. So overall, this is the removal of difficult CBD stones. This is kind of my way of thinking about it. You want to create an exit path, make the stone smaller, remove the stone. If you can't remove all your stone fragments, think about what you're going to do in the setting of incomplete stone clearance. And it's just a very simple algorithm. If you have difficult CBD stone, if you have a tapered CBD, yes, then you can consider a dilation-assisted stone extraction. If not, then you can proceed potentially with lithotripsy to break up the stone into smaller pieces. If you're successful after dilation, you have duct clearance, you're good. If not, you can consider lithotripsy after your dilation-assisted stone extraction. Again, if you're successful, great, you have duct clearance. If not, consider placing a stent, bring the patient back for a subsequent procedure. Let's do this quickly. This is just a simple case. 87-year-old woman presents with acute cholangitis, elevated white count and liver enzymes on labs. Abdominal ultrasound shows a dilated duct with a large stone, and ERCP is performed. And I've already marked the stone for you there. It's very big. It's that big filling defect in the bile duct. What would you do for this patient? Now, I don't know if you can answer more than one choice, but pick your favorite answer. If it allows you to pick more than one, pick as many as you can, or pick as many as you think are appropriate. All that apply. Can you pick more than one?
No, it says one.
Oh, okay, you get one choice. Okay, so in general, there are a lot of choices that were selected. Balloon sweep and saline irrigation were not chosen, but again, you guys are limited in the number of choices you could pick. Let's go back to the slides. So, in order to break up this big stone, chose to do EHL. This is that shockwave therapy. Break up the stone into smaller fragments. You can see how effective that is in breaking this up. So after this EHL, you look at the cholangiogram, and instead of seeing that one big filling defect, you just see tons of small filling defects there from all the stone fragments. In order to get the stone out, I dilated the opening to the bile duct. Okay, and then did a bunch of balloon sweeps to remove the stone fragments. So multiple techniques were used, right? So sphincterotomy, cholangioscopy-assisted lithotripsy, dilation-assisted stone extraction, balloon sweeps, and if the bile duct wasn't completely clear, I could have considered these other techniques as well. So just to conclude, most common bile duct stones can be removed with sphincterotomy and balloon sweeps. That's the majority of our procedures for bile duct stones, one and done. But difficult stones may require additional techniques to facilitate stone removal. Think about creating an exit path, making the stone smaller, removing the stone, and then dealing with incomplete stone clearance. And finally, difficult stones do not need to be removed in one procedure. Just remember, you can be patient. Okay? There's a stack of stones for you.